This is part one of a series of lectures on antimicrobial resistance and antimicrobial stewardship. In this part, we'll be talking about the when and why of use of antimicrobial drugs. So how do we approach making a microbiological diagnosis? Well, we generally perform this in a targeted way rather than exhaustively testing for all possible bacterial species. And we focus on identifying the most likely suspect based on the animal species that we're looking at, the site that we've sampled, and the history of the case. Most diagnosis is still based on microscopic examination of a stain smear and then culture of the organism from that sample. Once we culture that organism, we speciate those organisms that we've recovered, usually based on their metabolic characteristics. Susceptibility testing for susceptibility to different antimicrobial drugs is conducted in parallel with this speciation. Molecular diagnoses are rapidly becoming available and they offer greater speed in identification, but as yet not necessarily in susceptibility testing. However, all of this testing is relatively labour intensive and thus expensive, with culture and sensitivity generally costing in excess of $100. So what is the ideal approach to managing bacterial disease? Really, we could call this what would happen if veterinary microbiologists ran the world. Ideally, we would like to see samples collected from acutely ill animals when they're first encountered, and smears prepared of that sample beside the animal at the time that the sample is collected. The samples should then be sent to the laboratory immediately, accompanied by a full history of the case. And then, if the animal is severely ill, therapy is commenced based on an educated guess by referring to local antimicrobial use guidelines. Once a laboratory-based diagnosis is obtained, including antimicrobial susceptibility if it is necessary, therapy can then be adjusted, if necessary, based on that microbiological diagnosis. So what actually happens in veterinary medicine at the moment? Well, most antimicrobial therapy is not based on specific microbiological diagnoses. The diagnosis is often based on clinical experience, on gross pathology, and or past experience. This results in limited data being gathered on antimicrobial susceptibility of the organisms that we're trying to treat, and unfortunately there's no central collation of the data from different laboratories to guide our best guess for therapy. Most of the susceptibility data is gathered for companion animals and not from production animals, and the introduction of user-pays approaches to government laboratory services has unfortunately reduced both microbiological diagnoses and susceptibility testing in our production animals. The way we approach antimicrobial therapy varies between our production animals and our companion animals, and this is really a difference between treatment of groups and treatment of individuals. So in production animals, we generally treat them en masse, and particularly we do this in intensive management systems. Administration is typically orally, in drinking water or in food. The treatment is often prospective for a known endemic pathogen, especially respiratory or gastrointestinal tract infections that occur at particular times in the production cycle. We do some treatment in the face of outbreaks, sometimes when we have a microbiological diagnosis and when we have some antimicrobial susceptibility testing having been performed. We do have some restrictions on our use of antimicrobials in production animals, principally the maximum residue levels, which impose significant restrictions on usage and particularly limit off-label use. In contrast, in companion animals, we generally treat them as individuals. Administration typically is both parenteral and oral, and treatment is typically instituted upon recognition of some more or less specific clinical signs, but generally before or without making a microbiological diagnosis. Much of our use in companion animals is off-label, and really the only significant restriction to our therapy in companion animals are the rules of racing for horses. So what are the pathogens that we're trying to principally treat? So the key endemic pathogens in production animals are for the respiratory diseases, the mycoplasmas, the Pasteuracea like Pasteurella, Mannheimia, Actinobacillus, Haemophilus, Avibacterium and Bibistenia, and Escherichia coli in poultry. The gastrointestinal tract diseases, particularly Brachyspira and Lawsonia species in pigs, and Clostridium perfringens in poultry, and in feedlotted sheep and cattle, we're treating to prevent ruminal acidosis. And finally, we typically treat dairy cattle for mastitis, really to control gram-positive cocci and to some extent some of the Enterobacteriaceae. In companion animals, we're more commonly treating opportunistic pathogens like the gram-positive cocci and Enterobacteriaceae. We have some specific pathogens that we institute therapy for, including Streptococcus equi subspecies equi that causes strangles in horses, Rhodococcus equi which causes rattles, and Chlamydia felis in cats. Therapy is often driven by recommendations from experts, and often there is limited reference to published proof of efficacy or to the local regulatory environment. The choice of drug is commonly dictated by the ease of use, particularly the route and the frequency of administration, as well as perceptions of efficacy for treatment of that particular condition. There are some distinct issues that we face in antimicrobial therapy for production animals and companion animals. In production animals, the target of the therapy is usually defined. More often we have some susceptibility profiles of target organisms, although unfortunately many of these are often historical and sometimes ancient history. We have greater intensity of use and treatment of some unaffected animals, and usage is generally for a limited time period. In companion animals, the specific target of therapy is often less well defined. We have little published data on susceptibility patterns of local isolates of the key pathogens, and use is generally limited to small numbers of animals, but a wider range of agents are in use and there are less stringent controls on the agents that we're using. We have closer contact with the human community, and individual animals are much more mobile and move much more widely throughout both the human community and the animal community. This short lecture has been sponsored by Agriculture Victoria, the University of Melbourne, the Asia Pacific Centre for Animal Health, and the National Centre for Antimicrobial Stewardship.